to welcome Emel Hamilton to the stage. Dr. Hamilton is a global leader of clinical systems at Fresenius Medical Care, and she's going to talk about a really important topic on the challenges of IT and AI integration. So.
Thank you very much. Hi, everyone. You'll notice that I'll be standing stationary behind a podium today thanks to a recent ankle injury. But don't worry, the ideas will be moving fast even if I can't. So I'm very grateful to be with you today. A little bit about myself. I've spent most of my career at the intersection of medicine, data science, and technology. And this is the space we call clinical informatics. And it's a field where we translate between technology and clinicians, between frontline workflows and back-end systems, and between technology and clinical relevance. And today I want to talk to you about the challenges in AI integration. All right, so this is a topic that is exciting yet frustrating, because while the potential of AI in healthcare is enormous, the reality of actually implementing it, that's a whole different story. Let me just share with you an interesting fact. Most AI projects in healthcare, they don't make it past the pilot phase. In fact, about 85% of healthcare AI tools never reach clinical deployment. And it's not because the model is faulty, it's because the environments they're deployed into, our health IT systems, our workflows, our governance structures, they aren't designed to support them. So let's take a closer look in the next 15 minutes to some of these core challenges and that stay in the way of AI integration and what we can do about that. So I'm going to start with the obvious. Our health IT systems, they weren't built with AI in mind. They were built for billing. They were built for documentation. They were very painfully built for regulatory compliance. But they weren't built to easily talk to each other, let alone an AI model trying to make clinical decisions in real time. So you will know this in many hospitals and clinics you go to, there are dozens and dozens of siloed systems. There are different EHRs, different lab systems, pharmacies, pharmacy platforms, billing platforms, you name it. And getting these systems to exchange data is an uphill battle. So what can we do? Well, obviously, we can't rip everything out and start over. So we have to invest in interoperability. Interoperability as a strategy. We need to allocate budgets for integration infrastructure and data governance, and foster a culture of collaboration to address this problem across departments. But here's usually what happens. The business leaders will get excited and they'll fund that shiny AI pilot. But when you start talking about application programming interface, data governance, middleware, they'll start tuning you out. Their eyes will glaze over. But without that boring sounding stuff, none of the magic works. The model can't see the patient. The data can't move, and the insights stay locked behind siloed systems and data lakes. So we have to do two things. One is articulate the value of a robust infrastructure clearly. And number two, and this is just as important, find a way to make it compelling. So make it real. Tie it directly to clinical outcomes, patient safety, operational efficiency, financial efficiency. So we need to help our business leaders understand that investing in clean and connected data is really what actually unlocks AI's potential. So if you imagine the AI model as the plane, and the integration is the runway. So without that runway, we're trying to launch this cutting edge technology from a gravel road and then wondering why it failed. Why doesn't it take off? So we need to be persistent about framing the infrastructure not as overhead or some expense that we must spend, but as a part of the organization's strategic plan. So here's another reality. AI is only as good as the data that we feed it. And clinical data, you know it's messy. And let me tell you a quick story about a dialysis catheter. A patient is admitted with a tunneled dialysis catheter. In the nephrology note, it's documented as a permacath. In the surgical consult, it's called a central line for dialysis access. The radiology note describes it as a right IJ catheter. And the dialysis unit, they refer to it as a LTC on the right side, meaning long-term catheter. 4 different names, 1 device. So now imagine trying to build an AI model to flag catheter-related bloodstream infection risk, or even just generate a report to see how many patients have catheters. And you can see that gets real complicated really quick. In the past, there have been some global data standardization efforts like HL7, Loin Code, SNOMED, and you're probably familiar with these acronyms. And they all try to help us move data between systems by controlling the semantics. But they all tell us to document in rigid codes and templates. And then, frankly, the clinicians are tired of it. So what if I tell you it's time we flip that model? What if we let clinicians speak naturally? Let them enter permacath, if that's what they know, and use these large language AI models to map those variations to the same underlying concept. It is possible now with the advent of generative AI and all the newer tools, but it doesn't happen on its own. It requires a shared responsibility and an organizational commitment. First, the system designers really need to build these systems around clinical workflows, and we talked about this. And next, the business leaders need to allocate budgets, dedicated resources to solve this problem and put together some cross-functional teams made up of clinicians, informaticists, prompt engineers, computational linguists, and others. Because the future of clinical data, I believe, isn't about forcing everyone to document the same way. It's about letting people speak the language of care and then building systems smart enough to understand it. And one of the biggest myths about healthcare is this. If you build a good model, people will use it. Is that true? No. Clinicians are busy. We don't need another pop-up. We don't need another red flag. We don't need another system telling us something that we already know. Or worse, telling it at the wrong time. If AI alert, think about it, if AI alert fires after I've already made my decision, it's just useless. Or if it fires too early and I don't have the patient in front of me, it's noise. So the magic isn't just in the model, it's in the timing. It's about delivering the right insight to the right person at the right moment, using the right method without getting in the way of care. And then I want to talk about the right method for a second, because even the most brilliant alert can fail if it shows up the wrong way. So floor nurse, they're busy. They can't respond to an alert buried in a dashboard. But a case manager might appreciate that dashboard view. And not every alert belongs on a mobile device. If you send push notifications every hour, It's not a clinical tool, it's nuisance. So that's how you get alert fatigue, folks. Because at the end of the day, no matter how advanced the technology is, it still needs to fit into this messy human rhythm that we call clinical care. And if it doesn't, guess what? It won't be used. Not because it failed technically, but because it failed practically. So we all want to believe that AI will reduce administrative and cognitive burden, help us practice better medicine, maybe even give us back some time with the patients. But the truth is, many clinicians are skeptical, and with good reason. Because over time, the words electronic health records became synonymous with burnout. Interfaces designed with little input from frontline staff led to workflows that are not just inefficient, they were disconnected from the realities of life. So the result is hours spent after clinic, not with patients, not with loved ones, but with screens, updating charts and clicking boxes. So worse is when the frontline teams give feedback and it's ignored. And when that happens, the message to clinicians is loud and clear. This tool wasn't built for you, it was done to you. And so the result is disengagement and mistrust. So instead of helping providers, sometimes these tools become obstacles. So yeah, the clinicians are skeptical. And the path forward isn't about building better AI models, it's about rebuilding trust. So, and that begins with long before the first prompt or the first code is written. It starts with empathy. We need to listen first to understand what the clinicians experience in the course of their day before we even start solutioning. Empathy maps, not specs, should be our foundation. And clinical informaticists are uniquely equipped to lead this work. They know how to translate lived clinical experience to design specs and language that data scientists and engineers can understand and act on. But we can't just stop at design. We need collaboration with clinicians, not just once, but continuously. It means creating these feedback loops where clinicians can challenge, refine, and improve the model. And most of all, it means leading with humility, acknowledging the limits of our technology, listening when it falls short, and a willingness to say, we're still learning. I always say technology problems are much easier than people problems. And you know this, sometimes the biggest barrier to AI integration isn't the model or the data, it's organizational alignment. It could be the friction between departments and stakeholders. It could be misalignment between leadership expectations and frontline teams. And sometimes it's the hesitation that comes from not understanding the value of these tools. At the beginning of each AI project, some critical questions need to be asked. And this is to assign accountability. Who owns this model? Who owns the change it's going to create? Who's going to maintain it and monitor the key performance indicators? And perhaps most importantly, who's accountable when it doesn't work as intended? And as you can see, these aren't technical questions, these are human ones. And if there is no leadership alignment, the AI project will lack purpose, impact, and accountability. And if there is no clinician engagement, it will become simply shelfware, something full of promise but never used. So what I'm saying is, and Julie referred to that, AI cannot be just a set it and forget it type of project. Leadership must approach it as a strategy that's long-term strategy with clear oversight, active change management, adequate funding, consistent communication, and ongoing education. And finally, we need to get smarter about how we frame and measure success. It's not enough to say the tool gave accurate predictions. The model is 91% accurate. Well, that sounds great, but it doesn't translate into better patient care, so we need to dig deeper. How does that affect clinical decision making? Does it lead to improved outcomes and save lives and limbs? Does it improve workflows, or does it just sound good on paper? So we need to rethink success beyond technical metrics and embrace a more holistic, clinically driven outcome criteria. And also remembering that sometimes success means discovering that the model shouldn't be deployed at all. And that's a win in itself. Now, throughout today's presentations, you have seen how AI has the power to help us see the invisible, the misdiagnoses, the underserved populations, the silent signals and data, and bring care to those who have been overlooked for too long. And if we want AI to truly transform healthcare, we must step forward, not just as adopters and users, but as architects of its future. And what does that mean for everyone? Well, for IT teams, it means building systems that truly listen to the clinicians. For healthcare leaders, it means treating AI as a strategic initiative. For clinicians, it means engaging with AI as active participants. For data scientists, it means developing models that go beyond accuracy metrics. And for all of us, it means taking responsibility, not just for what AI does, but how it integrates into clinical care. Because in healthcare, technology should never be a barrier. It should empower, enhance, and support the people delivering care. So thank you for listening, and thank you for your time.